Welcome back to the Deep Dive. Today we're digging into something really fundamental for specialist surgeons everywhere. It's that unavoidable clash, isn't it, between lifestyle risks and how well surgery actually goes.
Yeah, absolutely. And smoking is, well, it's the big one. Everyone knows it ramps up the risk of complications after surgery.
Right? It's almost textbook. But the tricky part, the bit we're focusing on, is the timing. What do we tell patients about quitting right before surgery?
Exactly. Think about the pre-assessment clinic. You've got maybe 2, maybe 4 weeks before the operation. That's your window.
Such a short window.
It really is. And the big question, the one that's been debated for ages, is if you push hard for someone to quit in that short time frame, does it actually help? Or, does it trigger that old worry?
The paradoxical risk thing, that quitting briefly might actually make certain things worse.
Precisely that fear. That somehow stopping just before surgery could backfire, especially with lung issues.
Okay, so let's unpack that. We need to move past the old anecdotes, the sort of received wisdom. We're after the hard evidence, right? What really dictates how we plan surgery and counsel patients.
That's the mission today. We're going deep into this massive systematic review and meta-analysis by Tang and colleagues published just this year, 2025.
Right.
It pulls together a huge amount of data to try and pin down the real impact of quitting, say, 2 weeks before, 4 weeks before, or even 8 weeks before, on all those outcomes that surgeons worry about.
So this Kang study, it's basically the definitive guide, moving us from just guessing to actually having solid evidence.
That's the idea. We want to pull out the really actionable stuff. What do specialist surgeons need to know from this mountain of data? How does it change the conversation in that pre-assessment clinic?
How does it help justify maybe delaying an elective case if someone needs more time to quit? That kind of thing.
Exactly. It's about using this quantitative risk data to make safer decisions.
Okay, before we jump straight into the timelines, the 2 weeks, 4 weeks stuff, let's just set the scene a bit. Why is this such a big deal? Remind us of the scale of the smoking problem in a surgical context.
Well, it's huge because tobacco is still, the #1 preventable cause of disease and death worldwide. It's just a massive global health burden.
And that translates directly into surgical risk.
Directly. Even with smoking rates dropping in some places, globally, it was still around, 21% back in 2022?
And in North America, where a lot of our listeners are based.
Rates are lower than the global average, thankfully, but still significant. We're talking roughly 20% of adults in the U.S. still using tobacco, maybe 12% in Canada.
So think about the millions of operations performed each year. A big chunk of those patients walk in with this major underlying risk factor already baked in.
A huge chunk. Whether you're doing joint replacements, heart surgery, cancer resections, you're constantly dealing with patients whose baseline physiology is compromised by smoking.
And we know the long-term surgical consequences, right? The stuff that's always been associated with smokers.
Oh, yeah. It's well established. You've got the obvious pulmonary problems, makes anesthesia trickier, harder to get off the ventilator. Then there's the increased risk of heart attacks or strokes around the time of surgery.
And for specialties doing repairs, rebuilding things.
That's where it really bites. Wound healing is massively impaired. Higher rates of infections, wound breakdown, flaps failing in plastic surgery, anastomotic leaks in bowel surgery.
And bone healing too, right? For orthopedics and spine.
Absolutely. Delayed fracture healing, higher rates of non-union after spinal fusion. It impacts tissue repair at a really fundamental level. These are the long-term debts of smoking.
Okay, so that brings us back to the controversy, the reason this Tang review is so important. That traditional belief you mentioned about short-term quitting being potentially bad.
Right, the paradoxical worsening idea. For decades, the thinking was if you quit just, say, 2 or 3 weeks before surgery, you might actually increase your risk, particularly for lung problems.
It always sounded a bit odd, advising someone not to quit. What was the supposed mechanism behind that?
It was based on some specific short-term physiological changes people observed. The idea was that sudden withdrawal could temporarily ramp up inflammation.
Okay.
And at the same time, it might increase mucus production in the airways while also messing with the cilia, those little hairs that clear the mucus out.
So more sticky stuff, and the cleaning system isn't working properly.
Exactly. The fear was that this combination, more mucus-impaired clearance, could lead to things like collapsed lung lobes, atelectasis, pneumonia, difficulty coughing stuff up right after surgery.
And older reviews supported this caution.
Yeah, the older systematic reviews, maybe 10 years ago or more, they often only found really solid benefits kicking in after 4 or even 8 weeks of quitting. But part of that was likely because there just wasn't much good data published on those shorter intervals, that crucial 2 to 4 week window.
So Tang and colleagues specifically set out to fill that gap, to see if that 2 to 4 week fear was justified.
That was a key goal, yes, to rigorously examine that clinically vital period using all the available evidence.
So talk about the study itself. How robust was it? Can surgeons really hang their hats on these findings?
I think so. The rigor looks pretty exceptional. They ended up including 55 studies in the final review.
55, that's a lot.
It is, and it covers data from a massive number of patients, over 360,000 people. The average age was around 61, so definitely reflecting a typical adult surgical population.
And was it focused on one type of surgery, or did it cover a range? That's important for broad applicability.
Very broad. That's a real strength. They deliberately pulled data from all sorts of procedures.
Like what, for instance?
Well, there were 21 studies on lung or thoracic surgery, 7 on cardiovascular, 6 on GI surgery, 5 on breast surgery, reconstruction, oncology, and 3 specifically on spine surgery, plus others too.
Okay, so that breadth is good. It means the findings aren't just relevant to, say, lung surgeons, but potentially apply across many fields dealing with different types of complications.
Exactly. If you see a consistent pattern for pulmonary issues in thoracic surgery and wound issues in breast surgery, and maybe overall mortality in GI surgery, it lends a lot more weight to the conclusions.
And the quality of those 55 studies, did they look at that junk in, junk out
They
right?
did, and the quality was generally rated as high. They used the Newcastle-Ottawa scale, the NS score, for the cohort studies, which made up most of the evidence.
And how did they score?
The prospective cohorts averaged 8.4 out of 9. That's really good. It means the studies generally did a solid job defining their patients, measuring outcomes properly, and trying to account for other factors, confounders.
So good quality observational data overall.
Yes, synthesized carefully. But there's one major caveat we absolutely have to talk about: the measurement challenge.
How did they actually know if people had quit smoking?
That's the issue. The vast, vast majority of these studies, 49 out of the 55, just relied on patients saying they had quit. Self-report.
Okay. And we know people aren't always entirely accurate about that, especially when talking to doctors.
Exactly. There's definite potential for responder bias. People might say they quit when they haven't, or maybe just cut down. Only 6 studies actually used objective tests to confirm quitting.
Like breath tests for carbon monoxide or urine tests for cotinine?
Precisely, those biochemical markers. Because so few studies use them, we have to bear in mind that the actual benefits of quitting might be even greater, or perhaps require slightly longer, than what the self-report data shows. It's a limitation inherent in pooling this kind of literature.
Right. Let's get into the results then. Starting with the lungs pulmonary complications. This is obviously huge for thoracic surgeons, major abdominal surgeons, really anyone doing big operations on the torso.
Yeah, respiratory function is so often the key to a smooth recovery after major surgery, and this is where the review really throws down a challenge to that old "don't quit just before surgery" idea.
But first, did it confirm the long-term damage? Do former smokers ever get back to the baseline of someone who never smoked?
No, and that's a crucial baseline point. The analysis confirmed that former smokers, even if they quit more than 8 weeks before surgery, still had a significantly higher risk of pulmonary complications compared to people who never smoked.
What was the number on that?
The relative risk was 1.57, so a 57% higher risk even after quitting for 2 months or more. It shows that some damage is long-lasting. The physiological debt persists.
Okay, so you never fully erase the history, but what about the short-term fix, the intervention in that tight pre-assessment window? What happens at the 2-week mark?
This is probably the headline finding, the most immediately actionable piece of data, compared directly to patients who kept smoking right up until surgery. Quitting for at least 2 weeks cut the risk of pulmonary complications by 27%.
Wow, 27%, just from 2 weeks of quitting.
27%. Relative risk, 0.73. It's a substantial reduction in risk achieved in a very short time frame.
That really flies in the face of the old concerns. What's the thinking now on why the lungs benefit so quickly? What's happening physiologically?
The main driver seems to be the rapid improvement in oxygen delivery. The big immediate change when you stop smoking is clearing carbon monoxide, or CO, from your blood.
Right, CO latches onto hemoglobin, takes up space where oxygen should be.
Exactly. It forms carboxyhemoglobin, which is useless for carrying oxygen. Within just 12 to 24 hours of stopping smoking, those carboxyhemoglobin levels plummet.
Okay.
This shifts the whole oxygen-hemoglobin dissociation curve back towards normal. Essentially, your blood suddenly becomes much more efficient at picking up oxygen in the lungs and delivering it to the tissues.
Including the airways themselves and the surgical site.
Precisely. And this rapid system-wide improvement in oxygenation seems powerful enough to outweigh those temporary negative effects, like the extra mucus or sluggish cilia that people used to worry about. Better oxygen delivery helps tissues cope and heal, even if secretions are a bit increased for a short while.
So the immediate oxygen boost basically trumps the temporary mucus issue. That makes sense. It strongly validates pushing for cessation, even if you only have 2 weeks.
It absolutely does. And the study also showed the benefit grows the longer you quit. It's progressive.
So it wasn't just a 2-week threshold, but a trend.
Definitely. 2 weeks or more, for 2 weeks, 27% reduction, RR 0.73. 4 weeks or more, 29% reduction, RR 0.71. 8 weeks or more, 8 weeks, 37% reduction, RR 0.63.
Okay, so 2 weeks gives a big initial hit, but you squeeze out more benefit at 4 weeks and even more at 8 weeks. Clear dose response.
They have very clear dose-response relationship for pulmonary health.
What about comparing people who managed 2 weeks versus those who tried but maybe only quit for a few days or right before surgery, less than 2 weeks?
So that comparison also reinforced the 2-week message. Patients who managed at least 2 weeks of quitting had significantly fewer pulmonary complications than those who quit for less than 2 weeks. The RR was 0.68.
So even if you can't get to the ideal 8 weeks, hitting that 2-week mark is demonstrably better than quitting later or not at all.
Correct. It solidifies that 2 weeks as a meaningful, evidence-based minimum target if pulmonary risk is your primary driver for intervention timing.
This is really where it gets interesting then, isn't it? For anyone doing major chest or abdominal work, this evidence directly, quantitatively, refutes that old worry about a paradoxical increase in lung risk with short-term quitting.
It does. The data says 2 weeks is safe for the lungs, and it's significantly better than continuing to smoke.
It simplifies things quite a bit for that pre-assessment clinic conversation, at least regarding respiratory risk.
Enormously. If lungs are the main concern and time is tight, you now have solid evidence to aim for that 2-week cessation period.
Okay, so the lungs seem to bounce back relatively quickly, likely due to that rapid CO clearance and oxygen improvement. But what about problems at the actual surgical site? Things like wound healing, infections, bleeding.
Yeah.
Issues that really concern, say, plastic surgeons, orthopedic surgeons, general surgeons doing bowel work.
Right. If the lungs benefit quickly from systemic changes, the local tissue environment seems to be a different beast altogether. It takes longer to recover from the chronic damage.
We're talking about things like poor wound healing, breakdown, maybe flap loss and reconstructions, or leaks where bowel is joined together, and anastomotic leaks.
Exactly. These rely much more on the health of tiny blood vessels, the microvasculature, and the basic cellular machinery of repair stuff like collagen production. And that local environment just doesn't reset as fast as blood oxygen levels.
So starting with wound complications in general, what did the review find? Is there a minimum time to quit to see any benefit for wound healing?
Well, if you compare different quitting durations against each other, time definitely matters. Quitting for 4 weeks or more, or 4 weeks, was significantly better than quitting for less than 4 weeks.
How much better?
It was associated with a 33% lower risk of wound complications. Relative risk, 0.67. So getting to that 1-month mark clearly reduces wound issues compared to quitting for only, say, 2 weeks.
Okay, so 4 weeks seems like a minimum target if your main worry is tissue healing, wound integrity. But, and this seems like a really crucial but, what happened when they compared that 4-week quitter group to people who didn't quit at all, the active smokers?
This is the finding that really gives you pause, especially if you're doing surgery where healing is absolutely critical, complex reconstructions, major bowel anastomosis, that sort of thing.
What did it show?
The study found no significant difference in wound complication rates between patients who quit for 4 weeks or more and those who continued to smoke actively right up to surgery. The relative risk was 0.97. Essentially, no difference.
Wait, so quitting for a whole month gave basically no measurable advantage in wound healing compared to just carrying on smoking?
For the outcomes measured and pooled in this analysis, yes, that's what the data showed. A month wasn't enough to make a statistically significant difference compared to active smoking for wound complications overall.
That's pretty sobering. Why would wound healing be so slow to respond? We know smoking is bad for it.
It really points to how deep-seated the damage is at the tissue level. Nicotine is a potent vasoconstrictor. It clamps down on those tiny blood vessels, reducing blood flow, oxygen, and nutrients needed for healing. That effect can linger.
And it's not just blood flow, is it?
No, smoking also directly messes with the cells involved in healing, like fibroblasts, which make collagen. It disrupts the enzymes that remodel the wound matrix, the MMPs. Building strong new tissue requires good blood supply, healthy cell function, organized collagen, and all of that takes time, probably much longer than 4 weeks, to recover significantly from chronic smoking damage.
So the implication is, if you're doing a procedure where a wound failing is catastrophic, like a big free flap or a critical bowel joint, 4 weeks might not be nearly enough pre-op cessation. You need much longer.
That's what this finding strongly suggests. While 4 weeks is better than 2 weeks, it doesn't get you clear of the risk profile of an active smoker for wound healing. You'd likely want to aim for 8 weeks or potentially even longer based on this.
Okay, let's shift to surgical site infections, SSIs. This is where the results got a bit weird, right? There was an anomaly.
Yeah, this was probably the most unexpected result in the whole review. When they looked at former smokers who had quit for 2 weeks or more, 2 weeks, they actually had a higher risk of SSI compared to people who had never smoked.
Higher risk than never smokers. That seems backward. We know smoking impairs immunity.
It does seem counterintuitive. The relative risk was 1.36, so a 36% higher risk of SSI in that 2-week group compared to never smokers.
Any theories on why that might be? Beyond just saying the studies were maybe too different, heterogeneous, could there be some weird temporary effect of quitting?
Well, heterogeneity is the most likely statistical explanation given the mix of studies, but if you had to speculate biologically, maybe. Perhaps a sudden withdrawal causes some kind of temporary immune dysregulation or inflammatory rebound, or maybe it shifts the balance of bacteria in the mouth or airways temporarily, making someone slightly more susceptible right at that point. It's really speculative, though.
And did they confirm the known link between active smoking and infection?
Yes, they did a sensitivity analysis which confirmed that active smokers definitely have a higher SSI risk than non-smokers. The RR there was 1.21, so smoking itself is bad for infection risk, as expected.
Okay, so what happened to this weird SSI finding when people quit for longer, like 4 weeks or more? Did the risk stay high?
No, it seemed to normalize. When they looked at the group who quit for 4 weeks or more, or 4 weeks, there was no significant difference in SSI risk compared to never smokers, RR 1.12, not statistically significant.
And compared to active smokers?
Also, no significant difference compared to active smokers, RR 0.92.
So the message for SS seems to be, 4 weeks of quitting brings your risk back into line with that of an active smoker, which is still higher than a never smoker, but it gets rid of that strange increased risk seen at the 2-week mark compared to never smokers.
That appears to be the pattern. Short-term cessation doesn't reliably reduce SSI risk below active smoker levels, but waiting 4 weeks avoids that odd spike seen relative to never smokers at 2 weeks. It's complex.
Very complex.
Yeah.
Okay, lastly in this section, bleeding complications. What was the story there?
Generally, for the shorter cessation periods, 2 weeks or 4 weeks, there wasn't a significant difference in bleeding risk compared to non-smokers.
That sounds reasonable. But then there was another unexpected finding with the longer cessation group.
Yes, another surprise. The group who quit for 8 weeks or more, or 8 weeks, actually showed a higher risk of bleeding complications compared to non-smokers. The RR was 1.37.
Higher bleeding risk after quitting for longer. That really goes against the grain, doesn't it? Usually you think smoking contributes to things like high blood pressure, which might increase bleeding.
It absolutely contradicts the general understanding. It's a finding that's hard to square with known physiology.
So how did the authors explain this one? Again, pointing to the mix of studies.
Pretty much. The discussion section suggests this is likely an artifact of high heterogeneity among the studies included in that specific U8-week analysis pool.
Meaning the result might be skewed by just a few studies with very different patient types or procedures.
Exactly. Imagine you have a few studies on major vascular surgery patients who are often older, sicker, maybe on blood thinners, and they happen to fall into the U8-week cessation group. Their inherent high bleeding risk could skew the pooled result, making it look like long-term cessation increases bleeding, when really it's just the underlying patient factors in that particular mix of studies.
A statistical fluke, potentially.
Yeah.
A type 2 error, masking the real relationship.
That's the most plausible explanation. So surgeons should definitely not change their practice based on this U8-week bleeding finding. It needs much more investigation and seems unreliable as it stands.
Okay, so we've looked at lungs, wounds, infections, bleeding. kind of drilling down into specific problems. Now let's pull back and look at the bigger picture, the patient's overall risk. How did quitting affect composite complications and ultimately mortality?
Right. Composite complications is basically a bundled measure. Studies define it differently, but it usually combines several bad outcomes, maybe pulmonary plus surgical site issues, sometimes adding cardiac events or kidney problems into one overall score of morbidity.
A measure of did anything major go wrong?
Pretty much. And just like with the individual complications, the baseline issue persists. Former smokers, no matter how long they'd quit, still carried a higher risk of these composite problems compared to people who never smoked.
Debt lingers.
It really does. For example, even quitting for 4 weeks or more, the risk of a composite complication was still significantly higher than for never smokers. The RR was 1.77.
Okay, but comparing quitters to those who kept smoking, was there a duration of quitting that made a real difference to overall morbidity?
Yes, and this is a key finding for overall risk assessment. Only the group that quit for 4 weeks or more, or 4 weeks, showed a statistically significant reduction in composite complications compared to active smokers.
And how big was that reduction?
It was substantial, a relative risk of 0.69, which translates to a 31% lower risk of experiencing any major complication.
31%. That feels really significant. So while the lungs get better at 2 weeks, you need to hit that 4-week mark to see a demonstrable drop in the overall chance of something going wrong systemically.
That's exactly what the data suggests. 4 weeks appears to be the threshold for impacting that broader, multi-system risk profile.
Did they also compare the 4-week group to the shorter quitters?
They did. And again, it reinforced the 4-week target. Quitting for 4 weeks or more was statistically significantly better than quitting for less than 4 weeks. RR 0.78.
So the message is pretty clear. If you want to meaningfully reduce the patient's overall risk burden beyond just the lungs, you really need to aim for at least that month of not smoking.
That seems to be the minimum duration needed to see those broader benefits across different organ systems start to accumulate and become statistically significant compared to smoking.
Okay, now for the bottom line outcome, mortality. Did quitting smoking actually save lives in the perioperative period?
This is obviously the most critical question. Because of the number of events needed for analysis, they only had enough data to look at the group who quit for 4 weeks or more.
And what did they find for that or 4-week group?
The results were, I think, clinically profound. Quitting for 4 weeks or more was associated with a 14% lower risk of mortality compared to continuing active smoking. The relative risk was 0.86.
14% lower risk of death, just from stopping smoking for 4 weeks before surgery.
Yes. It's a really powerful demonstration of the impact. When you think about the sheer number of surgeries performed on smokers, achieving that 4-week cessation target translates into potentially preventing a very significant number of deaths.
How does that change the conversation during surgical consent, do you think?
It makes it much more direct, doesn't it? Especially for elective, high-risk procedures. It's not just quitting might help, it's quitting for at least 4 weeks demonstrably reduces your chance of dying from this operation compared to if you keep smoking.
But again, important to keep it in perspective. How did that 4-week group compare to never smokers in terms of mortality? Did they get back to baseline?
No, they didn't. That same group, despite the benefit compared to active smokers, still had a significantly higher mortality risk than people who had never smoked. The RR was 1.40.
So 40% higher risk of death than a never smoker, even if you're quitting for a month.
Correct. The 4 weeks is life-saving compared to active smoking, absolutely. But it doesn't erase the underlying vulnerability completely. You don't suddenly become as low risk as someone who never smoked.
So if you're trying to synthesize all this for the specialist surgeon, planning a complex, high-stakes operation, maybe a big cancer surgery, major heart or spine procedure, what's the minimum time frame they should be insisting on based on this overall morbidity and mortality data?
Based on this evidence, for those high-risk elective cases where overall complications and survival are the major concerns, that forward mark really emerges as the critical, non-negotiable minimum target.
Because that's where you see the significant drop in both composite morbidity, that 31% reduction, and mortality, the 14% reduction, compared to operating on an active smoker.
Exactly. While 2 weeks helps the lungs, which might be enough for less complex or more urgent cases focused solely on respiratory risk, if you're aiming to improve the patient's overall resilience and survival chances through a major systemic stress like big surgery, the data strongly supports delaying electively, if possible, to achieve at least 4 weeks of cessation.
Okay, so we have these targets now, 2 weeks for lungs, 4 weeks for overall morbidity and mortality, based on this big review. But, like any study, it's not perfect. We need to talk about the limitations, the things this study doesn't tell us, which are just as important for making real-world clinical decisions.
Absolutely. It's crucial to understand the boundaries of the evidence. The authors themselves highlighted several limitations.
We already mentioned the big one, relying mostly on self-reported smoking status.
Right. That potential for bias runs through most of the included studies, but there are others too. Well, think about what people smoke these days. This review focused pretty much exclusively on traditional cigarette smoking. It explicitly excluded studies looking at e-cigarettes, vaping, or smokeless tobacco like chew or snuff.
That's a big gap, isn't it? Given how popular vaping is now, we're basically flying blind on whether the same timelines apply to vapors.
We are. The physiological effects might be different. The required cessation time could be different. We just don't have the synthesized data from this review to say. That's a major area for future research.
What else did the researchers flag as limitations?
The heterogeneity issue we discussed came up again. Because the 55 studies covered such a wide mix of patients, surgeries, and slightly different ways of measuring outcomes, they couldn't really drill down into reliable subgroup analyses.
Meaning they couldn't say, for example, if the benefits of quitting are different for someone having heart surgery versus someone having bowel surgery.
Exactly. Or if the optimal timing varies significantly by procedure type, you ideally need, 10 or more reasonably similar studies to do that kind of meta-regression properly. And they just didn't have that level of homogeneity within specific procedural groups. It limits the ability to give really tailored, procedure-specific advice based solely on this review.
Any other key limitations from the study design itself?
One other thing they noted was that hardly any of the studies tracked whether patients stayed quit after surgery.
So someone might quit for 4 weeks beforehand, have the surgery, and then start smoking again on day 2 post-op.
Potentially. And if that happens, especially if you're looking at longer-term outcomes like wound healing or bone fusion that develop over weeks or months, that post-operative relapse could definitely muddy the waters and confuse the results. It's a potential confounder that wasn't well controlled for.
Okay, so those are limitations within the study itself. But what about gaps in the type of information collected? Things that specialists or hospitals really need to know but weren't consistently reported in these studies.
Yeah, this is a big practical problem. While the review gives us good risk reduction numbers for complications, it found that the reporting of really key efficiency and economic metrics was very patchy across the studies.
You mean things like how long people stayed in the hospital?
Exactly. Length of hospital stay, duration of ICU stay, rates of unplanned readmission within 30 days. These are crucial metrics for hospitals tracking quality and cost.
And why is having that data linked to cessation so important?
Because it builds the business case for investing in proper support. We know now that 4-week cessation reduces overall complications by 31%. That's great. But if we could then say, and that 31% reduction translates into, on average, 1 less day in the ICU and 2 fewer days on the ward per patient, that's the kind of hard economic data administrators need to justify funding robust preoperative smoking cessation programs with dedicated staff and resources.
Without that data, it's harder to argue for the resources needed to actually help patients achieve these cessation goals.
Precisely. The clinical benefit is clear, but the system-level economic benefit isn't as well quantified by this review due to inconsistent reporting in the source studies.
Now let's focus on a specific clinical gap that's critical for certain specialties. You mentioned orthopedics and spine earlier. What about bone healing?
This is a major deficit in the current evidence synthesis. We know from lots of other individual studies and basic science that smoking is absolutely disastrous for bone healing. It dramatically increases the risk of non-union after fractures or spinal fusion surgery.
So surgeons in those fields know it's a huge problem. Did this big meta-analysis give them any clarity on how long someone needs to quit to improve bone healing?
Frustratingly, no. Despite looking at 55 studies overall, they found only one single study that provided usable data specifically on bone healing outcomes, like non-union rates, in relation to cessation timing. Just one.
One study out of 55. That's not much to go on.
Got it all. And what that single study found was even more concerning, in a way.
What did it suggest?
It looked at non-union after spinal fusion, and it found no statistically significant difference in non-union rates between patients who quit for less than 4 weeks, patients who quit for more than 4 weeks, and patients who were active smokers.
So even quitting for over a month made no difference to whether the spine fusion took or not, according to that one study.
That's what that limited data point suggested. It really implies that the negative impact of smoking on the biology of bone, impairing the bone-forming cells, osteoblasts, messing up mineralization, damaging the blood supply to the graft is so profound and long-lasting that even 4, maybe even 8 weeks of cessation might be completely insufficient to reverse it enough to measurably improve fusion rates.
That's a stark message for orthopedic and spinal surgeons. The 4-week rule that helps with overall morbidity and mortality basically doesn't seem to apply when it comes to getting bones to heal.
It seems not. For those procedures, surgeons really need to counsel patients that the risk of non-union likely remains very high, unless perhaps they achieve much, much longer periods of abstinence, although the optimal duration is still unknown. It's a critical area needing dedicated research.
So, given all these gaps and limitations, where did Tang and colleagues say the research needs to go next? What are the priorities?
They outlined a few key directions. First, we desperately need more procedure-specific analyses. We need focused meta-analyses looking just at outcomes after, say, major vascular surgery or complex head and neck reconstructions or specific types of joint replacements. That would give much more tailored guidance.
Makes sense. What else?
Second, we need studies that look not just at complete quitting cessation, but also at significant reduction in smoking. Is there a threshold, maybe smoking only 5 cigarettes a day instead of 20, where you start to see some benefits, even if it's not complete abstinence? That reflects a clinical reality for many patients who struggle to quit entirely.
Good point. And the third area?
Third, really nailing down the optimal timing for those slower to heal complications, especially bone non-union, but also maybe long-term wound integrity or hernia recurrence. How long does someone really need to quit to make a meaningful difference there? Is it 3 months? 6 months? We just don't know yet. #tag outro.
Okay, so this has been a really deep dive into some practice-changing evidence. Even with the limitations, it feels like we have much clearer targets now. Let's just quickly recap the main takeaways for specialist surgeons listening.
I think 3 key things stand out. First, the baseline reality. Quitting helps immensely compared to smoking. But former smokers always carry a higher risk profile than people who never smoked. That sustained vulnerability across multiple outcomes is crucial context.
Right. Second takeaway.
Second, for the lungs, act fast. Quitting for just 2 weeks or more significantly cuts pulmonary complications by about 27% compared to active smoking. This directly counters that old fear about brief cessation being risky for the respiratory system. 2 weeks is safe and effective for lungs.
And the third key point.
Third, for reducing the patient's overall risk burden, cutting down on composite complications and mortality, you need longer. 4 weeks or more of cessation is the minimum evidence-based target to achieve those significant reductions. 31% in complications, 14% in mortality, compared to operating on an active smoker.
But critically, even that 4 weeks seems insufficient for reliably improving outcomes like wound healing compared to active smokers, and especially for bone healing, where the needed duration remains unclear but is likely much longer.
Exactly. The 4-week mark is vital for systemic safety, but doesn't fix everything, particularly chronic tissue damage.
You know, this really makes you think. Given how clear the benefits are, starting at just 2 weeks and growing from there, and knowing that former smokers still don't get back to the baseline of never smokers, it poses a bigger question, doesn't it?
What are you thinking?
Well, should we really be viewing perioperative smoking cessation as just this temporary fix, just something to get someone through surgery? Or should that pre-assessment clinic visit, that moment of surgical urgency, be seen as the absolute critical starting point, maybe even a mandated starting point for initiating intensive, supported, lifelong cessation efforts?
That's a powerful thought, leveraging the teachable moment of surgery not just for short-term risk reduction, but as the catalyst for permanent change. The data certainly suggests the pre-assessment window isn't just an opportunity for surgeons to intervene. Perhaps it's actually a mandate to start that aggressive, life-changing process, recognizing that the benefits extend far beyond the immediate surgical recovery. It frames our role differently, doesn't it?